let's go to be the outline. So we shall look at childhood blindness and then look at some specific common pediatric disorders like amblyopia, strabismus, congenital cataract, congenital glaucoma, retinoblastoma, and some common causes of red eyes. And then lastly, and most importantly, we shall look at screening children for certain eye disorders and a summary of the measures we can all implement in preventing childhood blindness. By the way, is there any question from our previous encounters? Does anyone have any question from our previous lectures?
No, not for me. Yeah.
All right, that's fine. That's fine. So there are more people or more adults who are blind compared to the number of children who are blind. However, childhood blindness is very significant because when a child is blind, the child has so many years to live. Unlike an adult who becomes maybe blind from cataract or glaucoma at an age of about 70, that adult may live for maybe just about 10 more years. A child who is blind at an age of 4 or 5, that child has so many years to live. So we call something blind years. When you consider the things that make children blind, children have more blind years. That's the number of years someone will live with blindness. So you multiply the age the person is expected to live by the number of people who are blind, okay, at that particular age. So childhood blindness is very significant because of the huge or the large blind years associated with it compared to cataract. So in terms of numbers or prevalence, as we have discussed in previous lectures, we said cataract is a leading cause of blindness. But if you multiply the number of people with cataracts by the average number of years people with cataracts are expected to live, what you will have may just be equal to the fewer number of children who are blind, if you multiply that by the large number of years they have to live. I hope that concept is clear. Yeah, so there are lots of conditions that can affect children, okay, including those that they can have as they grow, like cataract and glaucoma. However, when we are talking about eye disorders of children, some of them are very unique in the extent that they are conditions that are associated with children. An example or examples are retinoblastoma, squint, some types of squint. Some adults may have squint, but largely most squints will be found in children. And then retinopathy of prematurity. Those are conditions specific for children. Why does it matter? Why is it important? I've already talked about the fact that even though in terms of number, the number of children who are blind from any cause may not be as huge as those in adults, because the children have so many years to live. They have a higher blind years. And also, a child being blind also affects the child's development, because a child who is blind does not see. That child will have a delay in walking, okay? Because when you can't see, you are afraid to even take a step. It also affects the child's learning, because you see to learn. So in terms of the child's education, psychological development, all those aspects of life are going to be affected. So it's really important you spend time to know about this, okay? There are certain conditions that affect the eyes of children, like refractive error, squint, ptosis, cataract, pterygium. That's if treatment is delayed for adults, it will not adversely affect the outcome of treatment. I want you to get this point very clear. So if an adult has refractive error, like me, I am short-sighted. That's why I'm wearing glasses. If I don't correct my refractive error as an adult, eventually when I later decide to correct it, the outcome of the treatment will not be very different. If I have a squint, if I have a pterygium, if I have a cataract or ptosis, it can be corrected at any time without affecting the outcome of the treatment. Okay. With the exception of certain conditions that are naturally progressive and can lead to blindness quickly, like diabetic retinopathy, glaucoma, and then certain eye infections. Most other conditions that affect the eye of adults, I mean, there's some flexibility in terms of the timing when they can be treated, but that's not the case when it comes to children. In the pediatric population, anything that will reduce the amount of light that goes into the eye, that's to stimulate the retina and send visual signals to the cortex, to the visual cortex, it will affect negatively the ability of the child to learn to see. And this can result in a permanent loss of vision. There's a condition we call amblyopia. We shall be talking about it briefly in the next few minutes. Okay. So these conditions, if they are not treated early enough, there is nothing that can be done to reverse the damage done because of the delay in treatment. All right. So it's quite essential that most pediatric eye disorders are treated as early as possible. I hope that point is clear. So childhood blindness is defined as a group of diseases or conditions that occur in childhood or early adolescence that, if left untreated, can result in blindness or severe visual impairment. And these are unlikely to be treatable later in life, okay? Or they are likely not to be treatable or to be untreatable later in life. That's the WHO definition. We already know the definition of blindness. We said blindness is defined as visual acuity of worse than 3/60, or counting fingers at 3 meters in the better eye, all right? In the better eye. So with this definition, if you apply it to a child, the UNICEF defines a child as any individual who is less than 16 years. All right. So any child who has a presenting visual acuity of worse than 3/60 in the better eye, or the person has lost his or her independence to navigate, that the person doesn't have a walkabout vision, we see that person has childhood blindness, or that child is blind. What are the common causes of childhood blindness? So there are problems that can affect the cornea, like vitamin A deficiency, which for now, at least in Ghana, we know that corneal scarring that results in childhood blindness from vitamin A deficiency has gone down because we routinely do vitamin A supplementation for children who are more than 6 months. So every 6 months they get during their routine immunization, they are given they are given supplementation of vitamin A until they are 5 years. It may be the case in other areas, hopefully in Liberia as well. So that has helped to reduce corneal scarring from vitamin A deficiency. Okay. Measles, because of immunization, has also gone down, but it used to be a very, very significant cause of childhood blindness. Ophthalmia neonatorum, certain practices like putting herbal medications on the eye can cause scarring of the cornea and can lead to blindness. Okay, certain infectious corneal ulcers can also lead to blindness. The next cause of childhood blindness is congenital cataracts. All right. So, like we had a whole lecture on cataracts, but we mainly talked about cataracts that is related to age-related cataracts that you mostly find in the adult population. But some children are born or they develop early in life opacities of their crystalline lens. Okay, so those are congenital cataracts. They are very significant cause of childhood blindness and visual impairments. Then we have refractive errors in children. That's when not corrected appropriately can lead to visual impairment and blindness. Then retinopathy of prematurity. So as general healthcare is increasing, we should expect that children, some preterm children who survive, most of them can develop retinopathy of prematurity. So we have to be aware of this, so that because in Ghana here now, neonatal intensive care unit services has really improved. So preterm babies that are born as early as 32 weeks, 33 weeks are all surviving. Most of these are given oxygen, and all these increase the risk of prematurity, retinopathy of prematurity. So it means we have to be aware of this so that we can screen for this particular condition and treat it so that it doesn't lead to blindness. Okay, so I know Liberia too, your neonatal mortality rates is going down. That means more neonates may be surviving because of better care that is being provided with time. So that's also a very significant cause of retinopathy of prematurity worldwide. It's more of a problem in the advanced countries, but now as things are improving over here and more preterms are surviving, it's also coming up in our region. Then we have congenital glaucoma. We learned from the lecture on glaucoma that glaucoma usually affects, one important risk factor for glaucoma is increasing age. Okay, but here we have people who are born or develop glaucoma at a very, very early age. All right, it's also childhood glaucoma or congenital glaucoma is a very important cause of um, blindness. I'll touch briefly on congenital glaucoma in the course of the lecture. Then we have other causes like from optic nerve disease, certain genetic or heritable conditions that affect the optic nerves or the retina. They are also important causes of childhood blindness. So how big is the problem? The WHO estimates that about 19 million children have visual impairments. And out of this number, 1.4 million of them are blind irreversibly. That's how huge it is. But as I said, you cannot compare this to the almost about 39 million people who are blind from cataracts. Because if you multiply this 1.4 million by the average number of years children are expected to live, you get a very large blind years. Okay, yeah. I think I've touched on this. Yeah, most of these data in Ghana here, the data we have for childhood blindness, they are usually collected from the School for the Blind. However, these have problems because it's not every child who is blind who gets to go to the blind school. Okay, yeah. Please, just a few minutes. Just a few minutes. Mary, I'll call you. Sorry. Yeah. So it tells you that the numbers that WHO may be reporting or the national figures we will be having from the various countries may not usually be very accurate. They are likely to be an underestimation of the problem on the ground. Childhood blindness is a huge issue that all of us have to help. So at your level as family physicians, this by the end of this lecture, at least we should know what to look out for and how we can all help to reduce this major problem. All right, so globally, it's estimated that the average, what do you call it, childhood blindness, the prevalence is about 1 per 1,000 children. However, if you go to to the low-income countries, the values may be as high as 1.5 per 1,000 children. You go to the high-income countries, you have it around 0.3 per 1,000 children. In Ghana, as I said, our studies are from data collected from the School for the Blind. and we have about 0.75 per 1,000 children. If you look at our population, it means currently, as I'm speaking, you have about 8,700 children who are blind. And the sad thing is that about 70% of this huge number, the causes of the blindness could have been avoided. Okay. So this, on the left, we have some of the causes that could be prevented. Okay. So corneal scarring, intrauterine, factors like infections, teratogens, like alcohol. They are all preventable causes of childhood blindness. Perinatal factors like retinopathy of prematurity and birth hypoxia. You know, this one will lead to cerebral palsy during the time of delivery. So the visual cortex will be affected and the child can have cortical visual impairment. The same way that the child will have delay in motor development can also affect the eye. But most of these can be prevented with better perinatal care. And then with better antenatal care, we can reduce the number of children who are delivered preterm. Because if you are delivered preterm, the risk for development of retinopathy of prematurity is there. So the more we are able to provide better antenatal care, we can reduce the incidence or the prevalence of preterm babies. And then certain hereditary diseases could also be prevented. How do we do this? By appropriately counseling couples. Okay, there are certain conditions or diseases that may be inherited in a dominant fashion. Let me show you this picture. So I saw these children just yesterday at my clinic. It's a family of three. There are three children, and all the three children have severe visual impairment. I'm not actually sure what um, what 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 specifically is causing their problem, but upon examination, you realize that their eyeballs essentially look very normal. It's likely the problem may be some genetic condition that's maybe affecting the brain. Like I told you in previous lectures, you don't need, it's not only a good eyeball that is required to see. You need a very good eyeball. You need a very good retina, sorry, an optic nerve, and the visual pathway up to the visual cortex. Everything should be normal. Okay, I saw them for the first time yesterday, so we are going to carry out some investigations to find out. But now the case is patient sees nothing, physician sees nothing. Okay, so when you examine the eyes, apart from the fact that they are not seeing well, the globe, the cornea, the lens, the retina looks essentially normal. The optic disc appears normal, but the patient is not seeing. So the problem will be maybe some syndrome that is affecting the the brain, okay, along the area where the visual pathway is. Okay, and the fact that all three children have the condition should tell you that this could be a dominant condition which is being inherited in a dominant fashion. So this one, if the couple were appropriately counseled, perhaps after the second child, so the first child is 21 years, the second child is 14 years, okay, and the last child is 5 years. So at least after these two, they could, I mean, and these are coming from some village. I'm sure even after this, they've not actually been referred for proper evaluation because this child is 5 years. And by the end of our lecture, we shall appreciate that when you have a child who is not seeing well, the earlier you intervene or you try to optimize the vision, the better. Because usually after 8 years, by that time, the visual cortex has already developed and the eye becomes amblyoptic. Afterwards, there's not so much you can do to improve the vision. So our main attention is going to focus on this one so that we can optimize the vision from whatever facilities we have available. All right. So these are treatable causes. When the child is blind from cataract, glaucoma, retinopathy of prematurity, uveitis, corneal ulcers or opacities. These can be treated, even though it's not easy. Treating children, like we all agree, is never easy because you have the mother or like the parents who should be responsible enough to be bringing the child to you. It's not like an adult who knows the consequences of maybe um, um, defaulting. These children are at the beck and call of their parents. So if the parents doesn't have much insight and doesn't see how important care for the eye is, this child will develop, blindness because intervention was not instituted appropriately and early enough. All right. So with this introduction, I want us to look at these few disorders. So amblyopia, I think I've been mentioning this. Every child after birth. Please, is there any question as of this point?
No.
Not yet, not yet.
All right.
No,
So we are all on the same wavelength. Thank you. All right. Yeah. So visual development continues to develop after birth. And normal visual development requires that each of the eyes should be seen clearly. So anything that will impair vision in an eye will lead to abnormal development of the visual center, okay, of the brain. All right. So if there is a decrease in the best corrected visual acuity, and this one could be in one eye or in both eyes, it can result in a condition we call amblyopia. It's normally or commonly referred to as lazy eye. Okay, lazy eye. So when you have somebody who has amblyopia, when you examine the eyes may look structurally normal. Okay, just that in some few cases you may be able to notice that there are some structural abnormalities, like if there is a cataract or they have some opacity in the vitreous or a problem with the optic nerve. But majority of them may have normal eye examination. Okay, so it's again another example of the patient not seeing anything and the doctor also not seeing anything. So the eye learns to see. All right, I put this picture there because I think it illustrates the point. If you have a plant growing, the plant needs sunlight to be able to grow, isn't it? Yeah, I remember in my high school biology, we learned about tropism, phototropism. So where the direction of the light is, that's where the plant will tend to grow towards. Okay, because the plants need light to be able to grow. In the same way that the visual cortex of the brain, which is located in the occipital lobe, also needs good light. Okay, good vision, formation of good image by the globe or by the eyeball for that center to develop. Okay, so to be able to see, it's not just your nice eyeballs that you require to see. You also need your brain to be able to see. Okay, there is a saying that the eye sees what the brain knows. If the brain has not learned to see, you may be looking at something, but you cannot perceive exactly what you are seeing. So in this picture, you can see that the pathway for light is blocked by this wall. So the plant is not growing as nicely as we saw in the previous picture, this one, compared to this one, because light is blocked. You need light for the plant to grow. It's the same thing. So compare this picture to the previous picture. So as light gets through the eye, it helps the visual cortex to develop. But here, the light does not actually, the image is not formed well by the eye. So we don't have any corresponding development of the visual cortex. All right. Good. So as I said, the condition is normally or popularly known as lazy eye. All right. Yeah. So they call it lazy eye, not that the eye is lazy, but because that part of the brain that is responsible for integration of whatever you are seeing did not develop properly and is not functioning properly. All right. So any problem of the eye that blocks or distorts lights coming into the eye can cause amblyopia. And these are some of the common causes. Ptosis, like we have learned in previous talks. Ptosis just refers to abnormal drooping of the upper lid. So if you have a child who has significant ptosis, such that the ptosis is blocking the visual axis, that eye can become amblyopic or that eye can become lazy. Okay, pterygium is not very, very common in children, but assuming a child has frequent ocular surface irritation and develops a pterygium that obstructs the visual axis, that eye can become amblyopic. Cataract, glaucoma, refractive errors, especially those refractive errors that are very different between the two eyes. Okay, if the amount of error in one eye is significantly different from the one in the other eye, it is a sure recipe for the development of amblyopia, as well as strabismus, squint, can also develop, can also cause amblyopia. So why should we treat amblyopia? As I said, if you don't um, recognize any problem that's maybe preventing the formation of a good image in an eye, it can lead to amblyopia. You have to treat amblyopia because there is just a window period. You may have a 1-year-old child who has amblyopia already. There are ways we can use to treat that amblyopia, okay, to try to gain back the vision, some of the vision loss as much as possible and cause the visual cortex to develop. But we have almost up to the time that the child is about 7 to 8 years. Afterwards, the brain is not as plastic. The plasticity of the brain affords us a window period to correct and treat amblyopia up to the age of about 7 years. Afterwards, it's very difficult to be able to reverse the damage that is done. All right. So in treating amblyopia, we attempt to teach the brain, okay, on the affected side, how to see well. Okay, if you don't do this, then the brain will never learn to see, and the child will never have good vision on that side. All right. Okay, so this is how normally things should be. So this eye images are sent through the visual pathway to the corresponding visual cortex. The same for here, but here, for one reason or the other, the left visual cortex is not quite well developed. It means the left eye will be amblyopic, right? But the right eye is fine. So how are we going to teach, or how are we going to teach this brain how to see? There are many methods. Sometimes, let me give this scenario to make it stick better. If you have 2 children, okay, there are 2 children in your house. One of them is your own child. The other is your maid. Usually, the maid may be doing all the household chores, like going to the kitchen to cook and doing everything. And your own child is not doing anything. All right. In the African tradition, if you are a female and you are going to marry and you can't cook for your husband, it's a recipe for disaster. So later it dawns on you that your own child is not able to cook, it's not able to do most of the things that your maid who has been working all the time is able to do. How do you think you can rectify this particular situation? What are the options? What can be done to ensure that your child learns to cook before the child is ripe for marriage? Hello.
Yes, doc. I did not get the
Oh,
question.
Yes. What are your thoughts? I should come again.
Yeah,
So I
please.
said, yeah, you have two children in the house, your own child, and a maid servant. The maid has been doing all the chores, going to the kitchen. She knows how to cook very well. She can do most of the child
Yeah,
is growing. You don't want
yeah.
the family to be embarrassed because your girl child doesn't know how to cook. How can you remedy this particular situation? What should you do, or what are the options? What can be done?
So I will stop the meal from
Mhm.
cooking, the maid
Yeah,
rather, from cooking, and let my child start to become actively involved in the preparation of food
exactly.
so that
That is
he will learn.
how. Yeah, yeah, exactly. And that's how we treat amblyopia. So if one eye has been doing all the seeing, it means the visual cortex that corresponds to that eye will be very well developed. Now, as I said, the brain is plastic and the brain can still mature up to the age of 7 years, 7 to 8 years. Okay, so if a child is noticed to have a lazy eye in maybe the left eye, as we see in this particular picture, then to treat that amblyopia, you can do things to impair vision in the right eye so that the left eye will be forced, okay, into seeing, and that will help this part of the brain to also mature and develop, even though it may not be to the same extent as this one. So basically, that is the principle, okay? And so the way we achieve this is by occluding the normal eye by patching, okay? Or
Yeah.
sometimes we use eye drops like atropine. Atropine paralyzes the ciliary muscle and hence impairs near vision in the better eye. So when atropine is put on the better eye, near vision is going to be impaired, even though the distant vision may not be affected that much. So if the child then, after you have done that, the child is given a lot of activities like near work, activities that will require that the child sees near. Because you have paralyzed the ciliary muscles in the right eye, the child will be forced to use the eye that is lazy. And the more the child does that, the more it will help the visual cortex that had not developed up to this time to also start to develop. All right. And in addition to these two, you want to optimize vision so that if this child had some refractive error, or maybe there was a cataract, or there was any problem that was causing poor image formation in this eye, has to also be corrected. So if there's a cataract, the cataract is taken out. If it's refractive error, that refractive error is corrected. Okay, then you either occlude or penalize the left eye with atropine, and then the other eye is forced to see. That's basically how we treat amblyopia. I hope it's clear. Yeah. So how do we detect amblyopia? There are some basic things that can be done. The last time on our first lecture, I talked about assessing for red reflex. It's a very, very simple test that can be done. It gives us a lot of information. Okay. So if the red reflex is intact, it means that the ocular media is clear. So if you check the red reflex in a child and the red reflex is dull, either in both eyes or is abnormal in one eye, it should tell you that there is a possibility that that eye could be amblyopic. All right, and then you can check the visual acuity for the two eyes. If one of them is not seeing very well, it could be a sign that that eye could be amblyopic. And then again, you check the alignment of the eyes, ocular alignment. If one eye is deviated, that's if there is strabismus, it could be a sign that that eye could be amblyopic. So usually what happens is that if one eye, for one reason or the other, is not seeing well, with time, the brain learns to ignore that eye. For your eyes to be aligned, it's a brain that controls the alignment of the eyes. So if one eye is always not seeing, that eye is ignored and that eye will look away. All right. So these are some signs that can help you to detect eyes that are amblyopia. Ophthalmologists treat amblyopia, but it's our responsibility as primary care physicians or family physicians, okay, to detect amblyopia and then refer appropriately. I hope that is clear. Yeah.
Yes.
So again, these are the predisposing factors for amblyopia. So if there is refractive error, if an eye has refractive error, clear images are not going to be formed. And the refractive error could be in both eyes to the same degree, or it could be worse in one eye. That's what you call anisometropia. So one eye could be maybe will have myopia of about -6, and one eye has myopia of about -2. Okay, the difference is so much. We call that anisometropia. So in this case, the eye with the worst error may not be seen well at all, and that eye can become amblyopic. If you have high refractive error in both, like both are -6, -6, both eyes could also be amblyopic. Or if there is opacity in the ocular media, like I said, you do your red reflex and it's down, maybe because of a cataract or a ptosis or anything, then it can also predispose to amblyopia. Or if the eyes are not well aligned, if the eyes are not well aligned and the child is looking at something, different images are going to be presented to the brain, and that's going to result in confusion. So how the brain adjusts to that is to ignore one of the images, maybe probably the image coming from, sorry for my voice today, I'm a bit under the weather. The image coming from the eye that is deviated will be ignored, and that eye can become amblyopic. So I'm going to illustrate that with these following diagrams. So in this eye, the left eye here, vision is normal because the power rays from infinity or from the objects are focused right on the retina. But here, there is a refractive error. So the image forms in front of the retina. So this eye is short-sighted. This eye is myopic. Okay. So because you form a clear image and an abnormal image here, this eye stands the risk of becoming lazy or becoming amblyopic. And the brain, with time, is going to ignore this eye. So to be able to correct this defect, this amblyopia from the refractive error, first correct the refractive error, and then for a period, allow the eye that was lazy, that had a problem, to be used more frequently. Okay, then with time, allow the two of the eyes to now see after you have treated the amblyopia for a period. So this eye has the image in both eyes being formed behind the retina. This is hypermetropia, okay, or long-sightedness to the same degree in both eyes. Both eyes can become lazy because you don't have good image from the eyes going to the brain. This eye, the left eye, is normal, but here the light is not even focusing on the retina at all behind the lens. It could be because of an opacity inside the lens, like cataract. Okay, so this eye can become amblyopic. This eyeball is deviated. So when the normal eye is looking at the house that is right in front, this eye cannot form an image of the house. It's rather form an image of a tree which is somewhere. So the brain wants to look at the house, but here we have a tree which is interfering. That causes confusion in the brain. So the brain will ignore this eye, ignore images that are coming from this eye, and that can also cause amblyopia. So in this case, the ophthalmologist or the pediatric ophthalmologist has to align the eyes, okay, has to straighten the eyes so that this eye, so after performing surgery to straighten the eyes, you now occlude vision in the normal eye by patching or by atropine penalization so that this eye will now learn with time. I hope that's clear. So to treat, again, I'm emphasizing the treatment, you want a clear media, we give spectacles to focus the image, and then we patch the good eye. Okay, we patch the good eye so that we can force the poor eye to use or to see. All right, so this is a picture of a child whose left eye has been patched or has been occluded. So apparently the right eye is lazy, the right eye is amblyopic. So the left eye has been patched so that for about 6 hours within a day, or some also do it 2 hours within a day, not during the time when the child is sleeping, but the time when the child is actively doing an activity that requires good vision. If you patch the good eye, the left eye is forced. All right. Yeah. So here I said that if a child has strabismus and then like one eye is deviated because the brain has ignored it, as you are forcing that eye to see, vision may improve with time. That's if you are doing it within the period when the brain is still plastic. But if there is any strabismus or eye ocular misalignment, it will not be correct. It will improve. That one may require surgery to correct it later on. So I talked about the use of atropine, and later you can read the notes. I think I've already explained this. So atropine 1% is put in the eye that is normal, in the non-amblyopic eye, okay? So that near vision in that eye is impaired, and the patient will be forced to use the amblyopic eye. One other condition that is worthy for you to know that you cannot miss as a family physician who may take care of children is strabismus. Strabismus or misalignment of the eyes is a condition which is quite common. About 4% of children less than 6 years have it. And about almost half of them, children with strabismus, can develop amblyopia, like I've already illustrated. And this can affect them psychologically. Children who go to school who have misalignment of their eyes, their friends will always be teasing them. They may not be able to learn well and all that. But most importantly, strabismus or deviation of the eye could be a very important presentation for an eye condition that could not only be sight-threatening, but that could also be life-threatening, a condition called retinoblastoma. I'll come to those slides, but when you have a child with retinoblastoma or anything that will result in poor vision in that eye will turn away. So when you notice a child with squint, that child needs to be assessed, okay, to find out what is causing that eye to turn away. I've had instances where a child presents with deviation of the eye, and then we do fundoscopy and we see that there is a tumor, okay, in that eye, retinoblastoma. So how do you detect that a child has strabismus or a child has squint? There are some basic tests that can be done. One of them is called the corneal light reflex test. So you just shine lights, okay, in front of the eyes of the child with your torchlight. Ask the child to focus on a distant object, and then you want to see the reflex. The cornea sometimes can serve as a mirror, like a convex mirror. So there will be a reflection on the cornea. So you want to look at the position of that light reflex. Normally, if the eyes are well aligned, the reflex should be central. It should be at the central part of the cornea. If the eyes are deviated, for example, if one eye is deviated towards the nose, then you find that the reflex will be more located temporally, like laterally. If the eye is deviated more away from the nose, then the reflex will be located more nasally, closer to the nasal border of the lingus. All right. Another test we can do, I'll show a picture to illustrate, is the cover and uncover test. Okay. I think the picture will help to make the explanation clearer for you. Then we also have alternate cover test. So you can do cover test, or you can do either the corneal light reflex to detect misalignment of the eye. So here we have this picture illustrating how we do the corneal light reflex test. So in the left hand of the examiner, he's holding some piece of ruler that has some colored drawings on it that will attract the child's attention. So as the child looks at it, he's also showing light from the pen touch to find out the location of the corneal reflex in both eyes. Okay, so that is the corneal light reflex I'm talking about. If you shine light in front of the eyes, you see this one. So usually they should be central. Okay, they should be central. This child does not have strabismus, but because of abnormalities, how the lids have been formed, the white part of the eyeball is a bit covered. And sometimes because of problems with the globe or the distance between the two canthi, it may result in what we call a pseudo strabismus. There is a way to differentiate between what a real strabismus is and what an abnormal, like a true strabismus is and what a false strabismus is. So this test or this picture is illustrating how we do the cover and cover test. Okay, so look at this first picture. You can see that the corneal light reflex here is more located towards the temporal or the lateral aspect of the cornea, whereas this one, the left corneal light reflex, is central. Okay, but if you are doing the cover test, so it means that if you ask the child to look at something which is distant, something which is far, about 6 meters away, it is this eye which is fixating on it. Now, when you cover the left eye with this device, or sometimes you can even use your hand, your palm, then you see that because the child normally prefers to use the left eye to see, perhaps because that eye sees better. When you close that eye, then the left eye, which was deviated initially, now tends to look straight to be able to take up fixation. So this eyeball is turned inward, okay? And inward turning of the eyes is a type of strabismus we call esotropia, all right? Outward turning of the eye is called exotropia. So esotropia is inward turning of the eyes, and outward turning of the eye is called exotropia, EXOTROPIA, all right? So look at this. This child has normal ocular alignment because the corneal light reflex is central. The left has esotropia because the corneal light reflex is more towards the temporal part of the cornea. And you can see that the eyeball has turned towards the nose. So this one is esotropia. And then the other one I talked about is exotropia. So compare this normal alignment of the eyes, central corneal light reflex. This one, the corneal light reflex, is not central. It's more located towards the nasal limbus, okay, towards the nasal aspect of the cornea. So this one is exotropia. So which type is this?
Esotropia.
Esotropia.
Good. Very good. Very good. So the left eyeball is turned inward. Okay. Sometimes it will be turned to an angle such that if you shine light in front, you may not even see the corneal light reflects on the cornea. If you can see clearly, I mean, just look closely. Can you see that the light reflects, rather than being located on the cornea, is located on the conjunctiva here? Yes, on the sclera. Can you see it?
Yeah.
Yeah, so it means the eye is really turned inward. But if the eye was well aligned, you should have seen the corneal light reflex at the center of both eyes. Okay, so the esotropia and the esotropia are types of horizontal strabismus. Okay, so the eyeballs are deviated horizontally. Sometimes we can have vertical division of the eyeballs. Okay, so one eyeball may appear higher than the other. If you look at this picture, you can see that the corneal light reflects. This one is not a very, very good illustration, but perhaps the left one is more obvious. Look at the position of the corneal light reflex. The right one is central. The left, the reflex appears to be more closer to the top of the cornea. So if it's closer to the top of the cornea, it means that the eyeball is looking down. Okay. So at least for your level, just know that the eyeballs are misaligned, and then you have to refer for evaluation by an ophthalmologist. But this one is a hypotropia because the eyeball is a left hypotropia. This one was supposed to depict a right hypertropia, but it's not very clear. Sometimes people who have vertical strabismus, children who have vertical strabismus from a lot of causes, sometimes maybe from problems with their fourth cranial nerve, okay, trochlear nerve, they will have to tilt their head to ensure that their eyes are well aligned. Okay, they tilt their head. So usually you may see those people with an abnormal head posture. But when you straighten their head and then you check the position of the eye, that's when the misalignments become very obvious. All right. Yeah. So strabismus in a child could be a sign of poor vision, and that child will need to be referred to see an ophthalmologist for evaluation to find out what is causing the strabismus so that it can be corrected during the critical period the child's visual cortex is still growing, so that the child will not become visually impaired or blind in future. I hope this point is clear. If you don't hear anything, I want you to take that home. It's very, very important. Children's eyes. So you don't find a child with strabismus and the child is basically about 2 years and tell the parents that, oh, when a child is growing, it will correct. It's not all the time that it corrects. Sometimes the eyeballs are looking or are misaligned because of a refractive error that needs to be corrected very early. Sometimes there could be misalignment of the eyeballs because of maybe a problem like a tumor, a retinoblastoma that has already destroyed the retina and is growing with time and can eventually kill the child. A child I delivered myself by cesarean section when I was in general practice, a child of one of my staff nurses, happened to develop retinoblastoma. The way it happened, they noticed that the child's left eye was always deviating, but it wasn't a constant deviation. Sometimes it is straight, sometimes you look outward. So when they went to an eye clinic to see an optometrist, he just unfortunately did not do a proper fundoscopy to notice it. So they were reassured that it could correct with time. It was never to be. So the deviation got worse. And when later I was then in residency at Confanoche, they came and we evaluated, we saw that there was a retinoblastoma, a childhood tumor that was quite really advancing. So when you see strabismus, kindly refer promptly and let the child be evaluated. Another childhood condition, eye condition that you have to know about is cataract. We know cataract, but we can have children who will have cataract. That's not the age-related type of cataract. Okay. Now, for all the childhood cataracts, about a third of them could be hereditary. I know a family where almost every child that is born has cataracts. Okay, so this is quite important because we need to identify the cataracts and treat the cataracts to prevent what? To prevent amblyopia. light needs to go into the eyes. The same way plants need sun to grow, the visual cortex needs good vision to be able to see. So these cataracts should be identified and referred early. You don't say that because the child is 6 months, you should go when the child is old enough to be able to withstand anesthesia at 2 years. That's when you are going to refer. It may be too late for that child. So this is also something very, very important I want you to know. So ideally, if a cataract is identified, you want to remove and treat that cataract surgically as early as possible so that the child's eye does not become amblyopia. So a white pupil is a serious condition in a child that needs to be referred. All right. Now, one thing with childhood cataract is that if it is bilateral, it is not as amblyopic as when it is unilateral. When you have a child who has a normal eye and one eye has a cataract, the eye that has a cataract has, the risk of developing amblyopia is very, very high. Okay, so that's unilateral cataracts need to be treated with even more urgency than a child with bilateral cataract. That's also a fact I want you to be aware. So this one is in the operation room. Speculum has been inserted into the eyes, and you can see there is an opacity, okay, within the lens. Okay, the pupils have been dilated. Then we have ptosis. Ptosis is drooping of the eyelid. Okay, this child in the right eye, there is drooping of the right upper lid, and it is significant. Why is this significant? Because it is covering the visual axis. Why am I saying it's covering the visual axis? Because you cannot see the corneal light reflex. You can see the corneal light reflex in the left eye, but the corneal light reflex is not visible in the right because the upper lid has occluded it. If you don't correct this ptosis as early as possible, that eye is forever going to be lazy. It's going to be amblyopic. I hope it's clear. Now, children who may have bilateral ptosis, they may always adopt a chin up position. Okay, their chin may always be up. They will tilt their head so that they can see below the drooping eyelid. So if you see any child with abnormal head posture, okay, you have to rule out an ocular abnormality. Yeah, this is a child. The last time when I give a talk on glaucoma, I remember I spent a session to talk about congenital glaucoma. That is quite different in a way from adult glaucoma. Because for them, because the eyeball is still flexible, any increase in the intraocular pressure will result in extension of the eyeball, like the size of the eyeball is going to increase and the cornea is going to increase. So when you see a child with such large cornea, okay, and big eyeball, what we call ophthalmos, it could be a sign of congenital glaucoma, and we need to bring the pressures in this eye down as quickly as possible. Otherwise, the optic nerve could be irreversibly damaged, and that child can be blind. So if you remember, I mentioned about a triad of symptoms that can be elicited in a child with congenital glaucoma. The child will be photophobic, there will be blepharospasm, and then there will be tearing, epiphora, okay? So because the cornea is being stretched, the child cannot tolerate light. So the mother will say that when you take the child to a lighted environment, the child is always closing the eyes. And sometimes you find the eyelids opening and closing spontaneously. That is blepharospasm, okay? And then tearing of both eyes. They are the classic symptoms for congenital glaucoma. So the eyes look big and the corneas look blurry and gray. And then we can have tumors of the orbit, orbital tumors that can affect children. Okay, how will these present? These, when you are evaluating them, you may see that the eyeball could be protrused. There could be impairment with movement of the eyes. Okay, and then you can also be able to palpate a mass, okay, in the orbit. The orbit is the cavity inside the skull that houses the eyeball or the globe, all right? If it's a vascular tumor and you auscultate over the globe, you may hear bruit, okay? We evaluate this by doing ultrasound scan, CT scan, or MRI imaging. Some of these tumors could be benign, like dermoid tumors or dermoid cysts, okay, or hemangiomas, or they could be malignant, so rhabdomyosarcoma, lymphoma, or in a child who has a neuroblastoma, there can be metastasis to the orbit. So you can have a metastatic neuroblastoma, all right? Or you could also have tumors that are affecting the optic nerves, okay? And it can grow and get into the orbit, as well as an ocular tumor like retinoblastoma that can also extend into the orbit. So if you see that a child's eye is protrused or there is ptosis or any of those things, please evaluate the child. This one is very important for me because not only is it sight-threatening, but it is also life-threatening when it's not recognized and managed early. Retinoblastoma is the most common ocular tumor of childhood. Please take note of that. It can affect one eye or both eyes, and usually you find it for children who are less than 4 years. Okay, they can present with a white pupil reflex. Okay, either the mother will notice it or you will notice it as you see the child. Okay, a white reflex, and you are finding a white reflex because the tumor affects cells inside the retina, and it will cause the retina to be detached. If the retina is detached, then you will not see the red reflex. So one of the differentials for a white reflex is a retinoblastoma, or anything that can cause a retinal detachment, as well as cataract or opacities of the cornea. They are all differentials of a leukocoria or a white pupil. So if you find a child with a white pupil, what some call cat eye, please, retinoblastoma needs to be ruled out. Okay. Yeah. And like I said initially, a chunk of them, about a quarter of them, can present with misalignment of the eyes. So never joke with any child who has a misalignment of the eyes. Make sure they have an ophthalmic review to rule out all these things. And you can confirm this by doing a CT scan. Okay. And you notice calcifications inside the globe. The disease is heritable, and it's usually because of a mutation in the tumor suppressor gene, okay, that affects the immature retinal cells, okay. It's a tumor of childhood. An adult cannot have retinoblastoma because by the time you are more than 6 years, your retinal cells have already matured. So it's a maturing retinal cells that can be affected by retinoblastoma. So we treat depending on the stage of presentation. If it's found very early, a very small tumor inside the eyeball does not spread to the orbit, we can treat. Sometimes in advanced countries, they can even treat and preserve vision in that eye. Okay, but in our area, most of the time they'll present when the cancer has advanced beyond the globe and it's already inside the orbit, and sometimes that's even metastasized to the brain or to even other parts of the body. At that stage, all that you can do is palliative. But when you find it early, you can do local treatment inside the eye, or if it's even big enough and it has not gone beyond the globe, then we can do enucleation. Enucleation is when you take out the eyeball, okay, then so that later you can put in prosthesis, prosthetic eyeball, all right. But if they come when it's too late, not even enucleating the eye can save the life of that child, all right. So look at this picture. There is a white reflex here. Okay, you have to rule out retinoblastoma. So this is the fundus of someone who has retinoblastoma. You can see this elevated lesion. okay, at the fundus. This child has a white eye. It could be cataract. This eye needs to be evaluated as early as possible so that if it's retinoblastoma, like it is in this case, the child can be treated. It is retinoblastoma indeed, but it doesn't appear to have spread beyond the globe. So this child could have the eye enucleated so that his life can be saved. All right. Yeah. By the time in Ghana here, when you go to some areas, by the time you see a case of retinoblastoma, they are usually at this kind of late stage. When it comes to this stage, we have to do imaging to ensure that the brain, like the tumors, has not already extended to the brain already. So when they come at this stage, we give systemic chemotherapy. It will allow the tumor to shrink a bit before the eye is enucleated. And then afterwards, further chemotherapy is given. So it shouldn't come this late. So we can find it early. Sometimes the mother may complain that, oh, I see this white thing inside my, and then a medical officer or a doctor anywhere will see, and because it may not be obvious at that time, reassure instead of referring for urgent fundoscopy or evaluation. Okay, so and this tumor grows very fast. So if you are seeing them again in the next few months, you may have this on your hand. When it gets to this stage, it is already too late. This is a case of a very advanced retinoblastoma. I saw this case almost about 2 years ago. Yeah. So here at this stage, it's just palliative treatment. All right. So yeah, there are some other conditions that I don't know whether you have any questions as of this point.
Yes, yeah, Dr. Teng.
Yeah, Patrick.
I have a question. Yeah. Now,
all right.
For us, because if we see this kind of, if we find this kind of presentation in clinic,
yeah,
and possibly plan for a referral.
Yeah.
And if parents refuse, to accept the referral, for is anyway something like chemotherapy could be started, even whatever stage the child presented with.
Yeah.
Yeah, would there be any benefit of starting chemotherapy right away without waiting for,
Yeah, so it's really a challenge, like I said at the beginning. And a child is different because a child cannot take decisions on his or her own. They depend on the parents to think for them. One thing with retinoblastoma in these cases, sometimes it could be bilateral but asymmetric. So when you see it like this, very early does not only save the child's life, but if it happens to be bilateral, it affords us the chance to pick the growing tumor in the other eye early enough so that it can be treated and preserve the eye and even preserve vision in the eye. Okay. If they are not, chemotherapy can be started at that level, but the other eye needs to be quickly examined to rule out a bilateral retinoblastoma. Because if it's found early, focal treatments can be done to save vision in that eye or even to preserve that eyeball and hence to preserve the child's life. So I think you have to, on your part, in fact, there's not even a condition that any ophthalmologist can manage. This one is the pediatric ophthalmologist who have to manage this. But at your level, if you have to refer, you can refer. If there is no pediatric ophthalmologist inside, you can refer to any general ophthalmologist, and at least they have some basis. They will know exactly what to do. Further counseling can be given to the mother over there. And on your part too, you have to counsel the mother about the condition. There are pictures of this on the net. Maybe they come when it is like this. You can let them know that if they delay, it's going to be like this. And eventually it can become like this. No mother wants to see the child going through this. Okay, I have a video I took of a child who had bilateral retinoblastoma. That was because when they were diagnosed early and then referred, they refused. They went for traditional treatment and misconceptions that the eyeball is going to be taken out and all that. So there are pictures of maybe a child at this stage whose eyeball is taken out, and then if this eye is fine and this enucleation was done early enough before the tumor has spread to the brain, prosthesis can be fixed so that it looks just like this eye, just that that eye cannot be seen. I mean, that eye cannot see. So when parents are told that there is a help that can be done if they report early enough, I'm sure they will do everything possible to go to wherever you are referring them to.
Yeah, so that in this case, should we patch the eye before we refer, or we just leave it like that to refer?
Oh yeah, I mean, in this case when it is taken out, this eye is not seen anyway, so you can patch the eye. You can give oral antibiotics because there can be supra secondary infection. You can give ointment, okay, to cover the eye.
Okay.
You can patch. But now I am involved in a retinoblastoma control program in Ghana here. We never want to see something like this, not even to talk about this, because we think that with regular screening, okay, childhood screening, like the way children, I don't know whether you do that in Liberia, but in Ghana here, children go for regular weighing, okay, for their immunization. When they go, their weight is checked and everything. We should also use that opportunity to be able to examine the eyes of children just by using a direct ophthalmoscope. If an abnormal red reflex is detected, that person can be referred to an ophthalmologist, and things like this can be picked up at a very early stage before it gets to this. Okay. All right. Is there any other comment or question?
Yeah, Dr. Oteng.
Yeah, Patrick.
Is it possible to do an eye transplant in a child like this?
Okay, so
like if
now,
if I'm an elderly person and I feel that the child possibly has a long way to go, and I decide to donate my eye to will it be possible to do an eye transplant?
Unfortunately, no, that would be very, very difficult to do because if you are transplanting the eye, it means that you are cutting the optic nerve. Okay, and there is no way that you can connect somebody's optic nerve to another one for it to work. What we do is corneal transplant. Like if you have a child, like for transplant in eye, what we do is corneal transplant. If you have a child who has a corneal opacity from any cause, or like, then and even that one, a living person cannot donate one eye for a corneal transplant. You can sign documents that when you are dead, your eye can be harvested so that your cornea is taken and sent to the cornea bank so that it can be used to treat people who are blind because of a corneal opacity. But we cannot transplant. I mean, for now, it has never been documented anywhere in the world where a whole eyeball has been transplanted.
Okay.
All right. Is there any other question? All right. So I want us to look at some common causes of red eyes in children. I think we had a lecture on red eyes. So this one is just a recap. Okay. Some common conditions that can make a child present with red eyes include blepharitis, nasolacrimal obstruction, allergic conjunctivitis, chalazion, odeolum, and then cellulitis, whether it's preseptal or orbital cellulitis. Yeah, so blepharitis just refers to inflammation that could be from infection of the eyelid. All right, so here you can manage by recommending warm compresses for the eyelid, giving your topical artificial tears because they can affect the production of tears and hence the ocular surface. And then sometimes you may have to give systemic antibiotics depending on the extent of late involvement. This one is very important because you have a lot of children, newborns, and other infants coming to you with recurrent discharge in one or both eyes. This one could be because of an obstruction in the nasolacrimal ducts. Okay, the nasolacrimal duct drains tears from the ocular surface. All right, so let's look at this diagram. So, like I showed you in the fundamentals in the introductory lecture, we have an upper and a lower punctum here where the tears will be stuck through or the tears will pass. Then the canaliculus, we have the upper and lower canaliculus. Then we have the lacrimal sac. Okay, then we have the nasolacrimal duct. That will empty into a space behind the nose. Okay. Sometimes some children don't have their nasolacrimal ducts or the tear ducts well canalized at the time they are born. So there will be accumulation of these things that are supposed to drain away from the surface of the eye, and that can result in recurrent discharges in the eye. And usually, this kind of discharge, the eye may not look that red. Okay, and when you press on the on the medial part of the eye, close to the nose, you may have the discharge coming back from the nasolacrimal sac into this particular area. We call that nasolacrimal duct obstruction. Okay. The good news is that for most children, about 90% of them, by the time they are 1 year, they will open spontaneously. All right. So we teach the caregivers or the parents to be doing digital massage of the nasolacrimal duct. That will help to open up the obstruction here. If it doesn't work and the child is about 1 year or more, then we may have to go ahead and do what we call stenting. We try to canalize or probing. We pass a probe through the ducts, through the nasolacrimal duct in attempt to open it. All right. So it's a condition that is quite common. Sometimes you can have infection occurring in the nasolacrimal sac. Okay, it can present with a very red and then a reddened edematous lacrimal sac area. I'll show you a picture shortly. This can give the children fever and they can become very irritable. We treat this one by giving systemic antibiotics, broad spectrum like amoxiclav, okay, cefuroxime, and then you also massage, okay, massage the swelling. If it's very tender, you don't have to do that. You have to give the antibiotics first. So that's a picture with a child with dacro cystitis in the left eye. Chalazion forms because of blockage of the meibomian glands, okay? So they are usually not tender. They are found on the lid margin. You can treat that by applying warm compress and then antibiotic ointments like tetracycline, okay? They can be complicated with blepharitis, or sometimes they can even lead to preseptal cellulitis. In that case, systemic antibiotics may be recommended. Okay, I want you to look at this. I talked about this in the previous lecture. Preseptal cellulitis, there is infection around the eye, but all that is going on is anterior to the orbital septum. Okay, so let me show you from this diagram. This one is the orbital septum. Okay, so sorry, here. Okay, so whatever infection that is going on does not go into the orbit. All right, so that's a preseptal cellulitis. And classically, for a preseptal cellulitis, there is no proptosis. Okay, the vision may usually be normal. Eye movement will not be restricted, and the conjunctiva usually looks normal. There is no injection of the conjunctiva. There is no swelling or edema or chemosis of the conjunctiva. All right. So we manage that with systemic antibiotics. That is preseptal cellulitis. The patient doesn't have to be admitted. In contrast to orbital cellulitis, which is an emergency, it's an ocular emergency because the infection has actually gone into the orbit. And there's so much swelling and pressure inside the orbit that the optic nerve here is being compressed, okay? And that can result in permanent blindness of that eye. And it can also spread into the brain and cause um, cerebral abscess or meningitis, that sepsis, that can be life-threatening as well. So orbital cellulitis is an emergency. It's a medical emergency, and it is an ocular emergency as well. So we have to be able to recognize it. So this one, patient has to be admitted and be treated with antibiotics after you have taken your blood for culture and sensitivity. All right. And you have to manage this one with an ophthalmologist. Okay. And usually, orbital cellulitis could develop from diseases of the sinuses. Okay, there are air spaces around the orbit. Sometimes when you have sinusitis, they can spread into the orbit and cause orbital cellulitis. So this one, you have to always do imaging, CT scan, to find out about whether the orbital cellulitis has gone to involve the brain, and also whether there are associated sinus disease. Like sometimes there could even be abscess, okay, fluid collection inside the sinuses that may need to be drained by the ENT surgeons. Conjunctivitis, all right. So what I want to talk about here are some of the common conjunctivitis that can be from bacteria or viruses or allergic conjunctivitis, or most importantly, in children who are less than 1 month, okay, or up to the age of 1 month. When they have conjunctivitis, we call it ophthalmia unitarum or unital conjunctivitis. This is very, very important because it's a very significant cause of corneal scarring that can lead to blindness in children. Okay, so ophthalmia neonatarum, the most common organisms that cause them are Neisseria, gonorrhea, chlamydia, which are both sexually transmitted infections. Okay, so when you have a pregnant woman who has these STIs and they are not well managed whilst pregnant and they deliver vaginally, SVD, then the child can contract these infections on the eyes and they can make the child blind. All right. Sometimes even a child could be delivered by cesarean section and still have ophthalmia neonatarum if maybe there is cross contamination on the ward. Like a child has the condition, one child has it, and then you don't wash your hands very well, you can transmit it to other children. These are some other causes. Sometimes you can have chemical causes of ophthalmia neonatarum, like certain eye drops could cause the child's eyes to be inflamed. Like this silver nitrate that initially was recommended to be used as prophylaxis to prevent ophthalmia neonatarum was itself found to be a culprit in causing chemical conjunctivitis. All right. So how do we prevent this? Treat STIs in a pregnant woman. When the children are delivered, their eyes should be cleaned promptly, and then the children should be given prophylactic eye drops. What is recommended is povidone 5% eye drop or tetracycline ointment. This one is given in Ghana here. Every child who is born is given these prophylactic eye drops or ointment to prevent ophthalmia unitarum. All right, and then if in spite of all this the child develops it, then it has to be recognized promptly and it should be treated very, very aggressively. Okay, so depending on how prevalent the discharge is, the eye needs to be cleaned sometimes as frequently as every 30 minutes. And then eye drops are given every 30 minutes to every 1 hour, okay, for about a day or two before the frequency is reduced. Because if you don't treat it that aggressively, especially for the type caused by Neisseria gonorrhea, it can result in corneal perforation and that child may lose the eye. Some of them too can result in systemic complications like sepsis and pneumonia, especially the type caused by chlamydia. All right, so you need to identify it early and manage it promptly and aggressively. Allergic conjunctivitis is very common. I think I talked about this in the red eye. I'll not want to bore you so much on this. And then subconjunctival hemorrhage, not very common in children, but they can be very frightening. Okay, when a mother sees that a child has this on the eye, and normally you have this in maybe someone who has coagulation problems or a child who is coughing so much. That Valsalva, the pressure inside there can cause some of the capillaries in the conjunctiva to break and lead to leakage of blood under the conjunctiva. Okay, so we call it a subconjunctival hemorrhage. Okay, so with this one, they don't need any treatment. They will usually resolve in about 2 weeks. So how do we prevent all this? I'm getting to the end of my talk. How do we prevent all this? What are our roles as family physicians? Okay, what can we do? By doing screening. Okay, anytime you see a child, let's use the opportunity to at least have a look at the eyes of the child. Okay, please just a second. Sorry. Yeah, Oko. I'm the secretary for GMA. I'll lock it when I'm going. Yeah, yeah, she's gone. All right. So sorry for that interruption. So how do we do pediatric eye screening? So we screen right from the history to examination. Okay, so the history, the parents or the caregivers may have some worries. They may notice that the child is not seeing well, and that's a very, very important complaint you have to take note of. Or they may have noticed that the child's eye sometimes deviates. They are more with the child, so they are likely to notice any change in the way the child sees. All right, so take note of their symptoms. And then from their birth history, were they delivered premature? If they were delivered preterm, you know that they have to be screened for retinopathy of prematurity. All right. Was the pregnancy normal, or there were issues in the course of the pregnancy that could have had an effect on the child's eye development? Okay. How was the delivery? And then, is there any history in the family of childhood eye disorders like cataract, like refractive error, like retinoblastoma? Okay, yeah. And then with your examination, you want to check how the child sees. We learned about checking for visual acuity, but that was for an adult. If you have a child, you will not be able to use the Snellen's chart to check the child's visual acuity and document as maybe 6/6 or 6/9. No. So for a child, depending on the age, there are age-appropriate methods of testing for the child's vision. So for like the infants or those who are younger than that, or the very, very young children, the toddlers, you can just look at how the child physics. So maybe you take any colored object and then you check, or maybe just with your torchlight. Okay, as you move the torchlight around, you observe how the child is following it. Okay, is the child following your light or your object? And is the child's eye steady or the child's eye is wobbling? What we call nystagmus. When a child's eye keeps moving spontaneously, it's not able to remain fixed. Any eye that has nystagmus likely has very poor vision in that eye. So the eye is trying to fix on what it wants to see. So if there is nystagmus, it must tell you that that child's eye is not seeing well. In the older children, there are certain charts you can use to check their vision. Okay, this may have pictures and some drawings that the child can be familiar with. Okay, there are also some that have E's in different direction. We call it tumbling E chart. Okay, where the child will tell you where the three legs of the E are pointing to. Okay, in the school, children at the school age, you can use the Snellen's chart to check their vision. Okay, then again, I'm talking about red reflex. To check the red reflex, and the red reflex normal, is it equal in both eyes or it is asymmetric? If it is asymmetric, there is a problem. The child needs to be seen. Then check for ocular alignment, alignment of the eyes by using your corneal light reflex or by your cover and uncover test. I think I've already stressed on this. Why it is important for us to find disorders in children's eyes early enough. Children who may not be seen in one eye may always be found to be rubbing the eye. It's not always that it's because of an allergy. Okay. But if they are not seeing well, they may rub that eye because the child thinks that there is something there that is preventing them from seeing. Okay, so a child who rubs the eye so much will need the eye to be evaluated to rule out any problem, right? So the parents may complain that there is this white patch in the child's eye, all right, or the child's eye has become big, as we have in congenital glaucoma, all right. So a parent's complaint of a white patch in the eye, that could be as a result of cataract or retinoblastoma or retinopathy of prematurity. They cannot give a white appearance within the pupillary space. So this child has abnormal red reflex. Okay, the red reflex is absent in the right and is normal in the left. Okay, so this child should have the eyes examined. These are the tools that you need for screening. You need your ophthalmoscope. It's an eye patch. Okay, sometimes if you want to test for vision in one eye, unlike adults where they can use one hand to cover the eye, it's difficult in children because they may be peeping through the fingers. Okay, so it's better you apply this plaster-like patch to occlude one eye so that you can test for the other eye. In children who are much older, you can use this occluder. That's your pen touch. And these are some charts. Okay, they are just like the Snellen chart. So a child can tell you that there's a bed, or there's a man on a horse, or there's a cake, a hand, a motorbike, a bed, telephone. Yeah. So they are called Allen's charts. Okay. And these are the tumbling E charts. So if you are checking for red reflex, the child should be at about an arm's length. Okay. And here you want to look at the two eyes at the same time. So you have to determine whether they are normal and equal, whether they are symmetrical. If there is any asymmetry, that child needs to be referred, okay, for further evaluation. All right, I've talked about red reflex. So which type of strabismus does this child have? I want to see whether we still remember. Which type of strabismus does he have?
This is the ISO.
Very good. So
Isotropion.
very good. So this child has esotropia of the left eye. Okay,
Yeah.
the left eye is deviated nasally. Okay, so he has esotropia, and you can see that the corneal light reflex is central in the right, but it is descented in the left. It's more closer to the temporal limbus. Okay, so that is esotropia. So as I said, there will be a lot of reasons why this eye has turned away. This child needs to be referred for evaluation. So here the red reflex is equal and symmetrical in both eyes, and the corneal light reflex is central. Okay, those are normal eyes. Okay, so if you have an infant, you can just check the reaction of the pupils to light. If the pupils react normally to light, that child's eye could be seen. All right, and then sometimes as you shine light to the eyes, if the child sees, the child will spontaneously close the eye. Or there is something we call blink to threat reflex. If a child or an infant is seen, maybe you intentionally send your hand close to the eyes as if you want to hit the child's eyes. If the child is seen, the child will see the threat and there will be a reflex to close the eye. So that could be an indication that that eye sees. Okay, so I think I've talked about this. So you want to see whether the child is able to fix and follow, okay, light or an object, and whether that fixation is maintained. Okay, the eye is not wobbling around, what you call nystagmus. An eye that has nystagmus is an abnormal eye. Okay, all right. Good. So this child, a patch has been applied to the left eye so that we can assess the right eye. So this interesting object that will be of interest to the child is put in front of the eye, and it will be moved around to see whether the child will follow that object. It will tell you whether the child is seen or not. So I just wanted to illustrate that it's always better to use a patch if you have it than to use an occluder. See where the occluder is. So you think that you are checking vision in the left eye, but the child is actually peeping. Yeah, sometimes if they are using their hands, they'll be looking in between their fingers. So if you have this patch, that's the best. Okay, that was what. And then in the infants too, one way we can use to detect whether they are seeing well or not is to use a drum we call the OPKN drum, the optokinetic nystagmus drum, or like the optokinetic nystagmus chart. Okay, so here the examiner is actually behind this particular chart. He's looking through this particular people, and there are some black and white stripes here. Okay, and this black and white stripes will be moving horizontally at a particular frequency. If the child sees, you notice that the child's eye will be moving frequently. Yes, we'll be following it left to right, left to right. If the child is not seeing, the eyeballs will not be moving. So that's an OPKN chart or drum. Okay, so that's the Allen chart I talked about. That's the tablet. Those who are about 5 years and know their letters, you can use the normal science chart with them. Okay, and then if you notice any abnormality, any ophthalmologist will check for refractive error in the child, and these refractive errors can always be corrected with glasses. Okay, so glasses are not only for adults. Children who have refractive errors need to have their refractive errors corrected. Okay, so that their brain, the visual center, can develop. The eyes will not be ambiguous. So in summary, these are all that we have been talking about. There are a lot of things that can cause blindness in children. Some of them could be genetic, and they could be prevented with appropriate counseling. All right, like the picture of the family I saw yesterday that I showed you, with that dominant heritable condition that results in visual impairment in them. Okay, yeah. Congenital rubella can be prevented. Okay, if mothers or women in reproductive age are vaccinated with the rubella vaccine, it helps to reduce the incidence of congenital rubella. When a mother gets rubella during pregnancy, it can affect the children. And not only can they come with eye problems like cataract, congenital cataract, and glaucoma, they can also have deafness, hole in heart, like cardiac abnormalities from this congenital rubella syndrome. All right. We can also prevent ophthalmia neonatarum with good antenatal care, and then you treat um, mothers who have STIs whilst pregnant promptly before they go into labor, right? And then when the condition develops in the child, it should be treated with all urgency, okay, so that it doesn't lead to scarring of the cornea. Then retinopathy of prematurity, we can also cause blindness. We have to ensure that um, number one, pregnant antenatal care is optimized so that we can reduce the rate at which preterm children are born. And also, preterm children should be cared for very well. You shouldn't overdose them with so much oxygen. That can also predispose to the development of prematurity. Sorry, retinopathy of prematurity. And again, we can screen children who are at risk. Okay, so if you happen to come in contact with any child who was vivid preterm, ensure that that child's fundus may have been seen by an ophthalmologist. Okay, so that if there is any problem, it can be managed. Okay, yeah, congenital cataracts. Those that are hereditary cannot be prevented except those that are caused by rubella by vaccination of mothers in reproductive age. All right, but even if the cataract has developed, it needs to be managed early enough. I cannot emphasize this point any longer. I mean, more than enough, because you don't want the child's eyes to be amblyopic. All right, we cannot prevent congenital glaucoma, but we need to identify it early and refer for the pediatrician to see. Vitamin A supplementation will help to reduce xerophthalmia, okay, dryness of the cornea, okay, that can lead to blindness, okay. And then vaccination is already helping to reduce measles. Education of our populace so that they don't use traditional eye medicine, all right? And then amblyopia, we can prevent amblyopia by regular screening of children. If there are issues, they are treated early enough, right? Children with refractive errors are given their prescribed glasses that can help to reduce amblyopia. All right, so we want our children to have healthy eyes for their future. All right, we all have roles as family medicine practitioners. If you see a child, it's an opportunity for you to have a look at the child's eyes. From this lecture, there are some few things you can do. Even if you don't have any instrument at all, just look at the child's eyes, okay, and have an impression whether you think the child's eyes are normal or not. If the child's eyes are not normal, you refer for evaluation by an ophthalmologist or by an ophthalmic nurse or by any of the eye care staff. All right. If there is any problem, it will be found out, and the child can be helped while still young. If you wait until they are more than 8 years, not much can be done to help the child. All right. These are my references. Well, I've been using the first two references constantly for most of these lectures, and then the last one. But the third one, I got some previous lecture notes that was given to you. I took some of the slides from it as well. All right. The slides will be made available so you can always refer to them. Thank you very much for your attention.